Hello, everyone. Good morning. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan, and Greater Los Angeles, California. So we're going to go ahead and get started with a series of questions you should and must ask your plastic surgeon. This is where you have to do your homework and you have to invest time and effort and think about the whole goal of the surgery. These are questions that you would not necessarily ask, for example, if you were to get your gallbladder out, because you know how the process is. It's pretty much done repeatedly the same way from one state to the next. But when it comes to explantation, that is removal of the entire implant capsule, all inflamed tissue, you go to 10 different plastic surgeons. Without a doubt, you're going to have 10 different answers. And within the practices of these 10 different plastic surgeons, you're going to get 10 different variations as to how they practice. So it becomes critical for you, the patient, to basically do your own homework, do your due diligence. Essentially, this is on-the-job training for all of us, literally. No one was truly taught us how to do a proper explant because the general convention is leave the capsule behind, don't worry about the capsule. It is not going to be a problem later on. Just remove the implant if this is an explant that's going to be done. And now many of the surgeons are slowly starting to accept the fact that the capsule must be removed because the patients are not improving. So again, the most important thing is do your homework, talk to the surgeon directly, not the physician assistant, nurse practitioner, medical assistant. Do your homework and look up what the surgeon's track record is on social media, and most importantly, verify through the surgeon's previous patients, because that ultimately is the true test. And last but not least, you want to see the high definition pictures and videos of the chest wall showing complete removal of the entire implant capsule, because this is the ultimate and only proof that the surgery was done in the manner described. So having said this, I'm going to go ahead and have Mar kind of read out questions you must ask your plastic surgeon so that you are well informed. This is what they call the informed consent, and you as a patient, you understand what you're signing up for.
Okay, so first of all, I just want to say thank you for joining us. My name is Mar, and I'm one of Dr. Khan's assistants. So we'll start by asking, are you a board-certified plastic surgeon?
So this is very important. Board certified means there is that one and true board that authenticates certified plastic surgeon. Unfortunately, there are a lot of so-called plastic surgeons right here, not only within Greater Detroit and also Greater Los Angeles, but all over the United States, where there are general surgeons, ENT surgeons putting in implants, taking them out. You have the cosmetic surgeons who are taking basically implants out, and they are not true board certified plastic surgeons. And you have to be certified by the American Board of Plastic Surgery, because that is the only one true board, and that is that logo by ASPS, the American Society of Plastic Surgeons, that verifies, authenticates that you're trained well. And it is extremely important that your surgeon is trained well.
Are you an en-bloc specialist?
So this is where, I quote my mentor who basically stated, we live in the Motor City. If you have a car transmission problem, you go to the car transmission expert. And that means that all what they do from 8 in the morning till 6 p.m. every day is car transmissions. In my practice, which is exclusively devoted to breast implant removal, that is removal of saline implants, silicone implants, and residual capsules, this is essentially my specialty, to the point where I talk heavily about it. I have my whole practice based around removal of implants, and I would classify myself as a en-bloc / total capsulectomy specialist, because that is essentially the gist and heart of the surgery. And this will be reproduced not only in my Facebook, YouTube lives, but in my many discussions I have with my many patients. So I will certainly classify myself as a breast implant removal expert.
Okay. Do you perform breast augmentation or explant only?
So I'm very happy to state that I have only done one augmentation in my career in order to get board certified. I never believed in implants from the very beginning. I thought they only ultimately hurt the patient, and so I did not want to make a career out of what is augmenting. So I only remove implants. That is, I remove saline implants, silicone implants, and residual capsules. Residual capsules meaning where the first surgeon did not remove the capsule completely or partially. and that my task is to remove the capsules. And so I have never augmented except for that one time on a cancer patient, and I only believe in explanting, and there is a proper etiquette into removing the implants.
What type of facility will my surgery be performed at?
So this is a very good question. You want to make sure your surgeon basically has a certified facility, which is by Quad A HC or Quad A SF, which is the gold standard of operating rooms. So at the Landmark Surgery Center, this is a Quad SF facility, which means it is the highest standard, the gold standard of operating rooms outside of the main hospital, to the point where many nurses, operating room staff, surgical techs, people who have worked at the hospital would prefer to be operated on at a setting like this versus at the hospital where it can be chaotic, and they have their own quote overall benefits and risks of doing surgeries there. Over here, it is a very controlled, systematic, thoughtful environment where we control the flow in and out, and it's a very private, nice, boutique, certified setting.
How many en bloc explants have you done?
So this is from the beginning of my career. I only removed the implants, and having practiced since 2014, I've been exclusively removing implants on and off. Initially, the first few years, it was very sporadic, and then one of my patients, basically who understood what my surgical approach was, put my technique on social media, and now we have what is the largest Facebook group following that we have of a plastic surgeon, and I'm blessed to say that this is essentially my technique. Now, this question I get asked a lot. Remember, it is not about the numbers, it's all about many factors that come into play. Number one, as a board-certified general surgeon, having taken care of a lot of patients with mastectomies, breast cancer, that is integral to the training. A lot of patients that have come to me with trauma, for example, gunshot wounds to the chest, to trauma to the chest, and being able to feel comfortable operating on the chest. Number three, a lot of thoracic surgery where the chest tube's in and out, along with other interventions that have come into play in the general surgery training, are key into training the mindset into operating on the rib. Remember, this is a surgery, relatively invasive. It is outpatient. It has its proper mindset of the surgeon where the entire capsule and implant must be removed off of the rib directly on top of the muscles of the chest. And in my practice, the periosteum, that is the layer directly on top of the bone, is removed. The perichondrium, that's the layer directly on top of the cartilage part of the rib, is removed. The fascia of the intercostal muscle is removed. That's the muscle in between the ribs. The fascia of the serratus anterior, and the fascia of the pectoralis minor, and also the fascia of the pectoralis major inferiorly, that is when it is below the muscle. And so the goal here is to do the surgery that is relatively very invasive that many surgeons don't want to even think about doing. And this is where it's more about the quality of the delivery rather than the quantity. So you see many surgeons out there who are doing 4 of these in a day, and you will see they will have a higher number of explants that they have done, and which may not necessarily correlate to the right surgery. So it's not more about the numbers, it's more about the quality of the explants. The other thing to discuss here, very importantly, is that the surgeon must be very transparent when it comes to discussing and showing the entirety of the implant capsule being removed, which means that a surgeon may do 1,000, but if they have no videos to show, we cannot validate that those thousands were done correctly. And so even if they have done 10,000, it will be a meaningless number because it was not the quality control. Now, in my practice, I can do only so many of these per day, which is on average 2, maybe 3. And I can only operate 3 days out of the week because, I have to have patients that I see before and after in clinic. And so this is a number where it's dictated not only by quality, but by transparency and by also validation on social media, not only by the patients who obviously are very intelligent and smart and they can process this, but also by the many plastic surgeons who follow one another, and especially me, as to why and how I do it in the manner that I do. And so it becomes critical for you, the patient, to understand it's not about how many you have done, but what is the quality, what's the transparency, and how you have done it consistently from one year to the next, from one patient to the next, and maintaining the highest standard when it comes to the surgery. This is a surgery that requires a mindset, a physical ability to be doing it, a ability to be doing it with transparency so that you can share your hard data, which is the high definition pictures and videos of the chest wall showing complete removal of the capsule. So having done this for almost 10 years, I would say, and talking about it heavily, that ultimately validates the number of cases that I have done.
How long will the explant surgery take?
So this is a very good question, and I find this is integral to doing the surgery correctly. In my hands, plus minus, an average implant 325 cc's, an average implant 325 cc's, it takes me approximately 4 hours, plus minus. And sometimes it has taken me up to 5.5, 6.5 hours just to doing one proper explant, because it was a ruptured 800 cc implant below the muscle, and she had residual capsules from her first set above. So that certainly adds to the overall extent of the surgery. I hear about many surgeons doing a surgery in 90 minutes. I find it impossible. That is virtually impossible to do. I would love to do a surgery in 90 minutes, but I find that will lead, no matter what and how good and fast the surgeon is, this surgery cannot be done in 90 minutes or 2 hours. And I see a lot of surgeons not only doing an explant supposedly, but also a lift and fat grafting in 2.5 hours, for example. It is, again, virtually impossible. You cannot expedite or process this surgery in a very fast, expedited manner. Remember, this surgery is not about speed. This surgery is about precision. This surgery is all about the surgeon taking his or her time and literally millimeter by millimeter off of the chest wall, dissecting the whole capsule, such that there is no doubt that that capsular tissue or inflamed tissue is left behind. And this is the 4-hour plus minus commitment. And we're not talking about a full lift. I do a pseudo lift during this 4 hours as well, plus minus. So every patient that comes in gets booked for plus minus 4 hours.
Okay, so that brings us to our next question. Is your goal to remove all of the capsule tissue from my chest?
Yes. So in my practice, the whole emphasis, goal, and that ultimate comprehensive removal of the entire implant, capsule, all inflamed tissue must be done with definitive certainty in what is called the en bloc fashion, where there is no break in the capsule, or 100% total capsulectomy, such that when the surgery is done, there is essentially no doubt that no capsular tissue is remaining behind and no inflamed tissue around the capsule is remaining behind. And that is essentially the essence and gist and heart of what is explant surgery. So in the vast majority of the cases, the implant is below the muscle, the breast tissue is above the muscle, and I do not dissect into the breast tissue. I'm always below, in the compartment below the muscle, so I do not touch the breast tissue. And this is where no extra or precious volume is removed. The entirety of the implant capsule and inflamed tissue is removed. We know this not only because of the many patients who I have taken care of with residual capsules who have improved dramatically, and that is the ultimate proof, the patient improvement. We also have the many patients with their pathology reports that states that it was silica or inflammatory cells that were present in that capsule and the inflamed tissue. There were patients with fat necrosis around in that inflamed tissue, and that's why it's critical to do the surgery correctly once, do it correctly the first time, so you do not have to second guess your surgeon, and that you have the ultimate peace of mind that it was done in the manner as described. So for example, if someone's surgery was done today and they put their head on the pillow, that first night they should have that absolute peace of mind that all of that capsular tissue, inflamed tissue, and implant was removed in what is the en bloc fashion or 100% total capsulectomy. And number two, whatever was removed was tested, so we know what it is and what it is not by doing the testing with microbiology and pathology, and we'll talk about that soon.
Okay. Is your goal to remove the implant and capsule as one unit or as a whole?
Yes, again, going back to the same point, the whole goal is to do it in en bloc fashion, which means implant, capsule, and all that inflamed tissue around removed, leaving behind all good, precious volume and removing all what is bad. And this needs to be done in en bloc fashion in my practice or 100% total capsulectomy. And this is truly the gist and heart of the practice. If you talk to 1,000 plastic surgeons, majority, if not all, will state that the capsule can be left behind. It is not a big deal. It's scar tissue. It has no bioavailability to it. No, in my practice, I know, just like I said earlier, the pathology report and most importantly, the patients essentially will give the feedback that the entirety of the capsule must be removed for the patients to bounce back completely to a state of good health, minus the toxins, minus the inflammation, minus the silicon toxicity. Because in those many patients where the capsule was left behind, the patients did not improve, and they knew deep down within they had sought that improvement. It was not complete to the point where they had to seek another surgeon out who then did what is residual capsule, which is a more important and a more difficult surgery. So another example that I will give here is a patient right here in town. She went to a plastic surgeon who supposedly did the surgery with removal of the capsule plus implant. Now, post-op, she improved 70%, but deep down within, she knew she still has those symptoms lingering on, and she knew herself, her body very well, to the point where she was not convinced that her surgeon removed the whole capsule. And then she sought out another surgeon, and that surgeon removed the residual capsule, and only then did she improve completely. And that automatically, those high definition pictures and the residual capsule in itself was the ultimate proof that the capsule was definitively not removed in its entirety. And remember, this is a mindset, and I've taken care of a lot of patients with the residual capsules who have only gone on to improve. And this goes back to the point, do the surgery correctly, do it once, get the whole capsule implant out right the first time. You do not want to go back for a second surgery. Another patient, unfortunately, said once, well, I have my insurance that's going to cover the case by a local plastic surgeon. If I don't improve completely, then I will come to you for residual capsule. And I said, do not want to do that, because if you have a ruptured silicone implant and it spills into the chest, no matter how much you wash out, no matter how much you try to clean up after, it will not be the same as doing the surgery correctly the first time.
Okay. Will you be taking any pictures or videos during the procedure, pre-op and or post-op?
So again, extremely important question. This is the one and only and the ultimate proof that your surgeon did the right surgery correctly to begin with, and that he or she feels comfortable and confident that he got the whole capsule and implant and all inflamed tissue out. If there is one test, one confirmation, one visual confirmation, it is this. Your surgeon may not speak to you even for a second. Your surgeon may not even share the operative record with you. But if he or she can share the high definition pictures and videos of the chest wall showing complete removal of the entire implant capsule, and you visualize what is raw rib, raw muscle right on top of the chest, you have that confirmation absolute that your surgery was done in the manner described. And so I say it is the number one and only confirmation that your surgery was done correctly. Otherwise, you will always be second guessing your surgeon and the whole process. You do not want to be in that phase, because remember, this whole surgery is about the capsule and inflamed tissue and the implant. Anyone can remove implants. This whole surgery is all about the capsule and the inflamed tissue and the implant being correctly removed the first time around.
Am I able to review photos of previous explant procedures?
Absolutely. So if you look at our website, between the YouTube shorts, if you go to YouTube and you go to the Facebook page. Facebook does not allow graphic pictures and videos, but if you go to YouTube Shorts and YouTube videos, you will see clearly the many high definition pictures and videos of the chest wall showing complete removal of the capsule. And also, as you will see, I have thousands of members on the Facebook group page. One patient can reach any one of those members and DM them, and they will be able to see clearly what are those high definition pictures and videos showing complete removal of the entire implant and capsule. And that is, again, the one and only proof that the surgery was done in the manner as described.
What is the average recovery time frame?
So this is a very good question. In vast majority of the cases, the implants are below the muscle, which means right on top of the rib. The muscle in itself inserts into the upper arm, which is the humerus. If you go to the anatomy and look at the pectoralis major, origin and insertion, you will see the muscle inserts into the upper arm. So, for example, if the surgery is done today and you have to drink a cup of water, absolutely type text, no problems, because that is digit and wrist function. But you cannot lift a gallon of milk because you will inevitably end up engaging the muscle. You have to essentially put a tie around your arms because that will mean that when you're sleeping, you're not going to stretch or move your arms out. So the elbows have to be always in towards the chest such that they are basically, the arms, upper arms are held in, and it's only the digit and wrist function. Within day 6, 7, or 8, 80-90% of my patients are easily driving 9 to 3, and they are comfortable going back to their desk job maybe at week 2, week 3 from the surgery. And again, relatively speaking, a very well-tolerated surgery. Not only are we talking about recovery, it is important to talk about relief. So many patients, for example, the 79-year-old patient with a ruptured implant, she's not only recovering from the surgery, but she has the relief of the capsular contracture. So now the patients are able to breathe better instantly right after the surgery because their capsular contracture has been addressed. If they have a ruptured implant, the weight of the implant, the inflammation, you see the dramatic recoveries from the patients with their eye dryness improvement or their migraines improving. So you see not only relief, but recovery as well. And overall, the relative 6 weeks go by reasonably fast. And again, you are in a limited movement, but you certainly are able to do quite a lot. At this phase in recovery, you do not want to be doing your dishwasher, for example, or doing a laundry, because that again means you're using a pec major muscle. You want to let yourself recover just like you would after a tummy tuck. So you're looking at approximately 6 weeks before you gently start doing the 2-pound weights with primarily bicep curls, and you are focusing on slowly building the muscle that truly was not used when you had your implants. Anytime you cut the muscle and you put the implant below, the muscle has been compromised because you cut the muscle. And anytime you have an implant below the muscle truly is not used because then you compress the implant against the chest wall, and that is a compromised muscle as a direct result. With the implant gone, if anything, the posture changes for the better, the neck, back, shoulder issues from the inflammation improves for those patients that have the fibromyalgia type issues. The weight of the implant being lifted off the chest in itself will help, and you will see the small subset of patients, both young and old, their palpitations, for example, also improve, and so there is recovery and relief from the implants in itself. And something, again, going back to the point where the many patients who have stated one of two things: they wish they had never gotten implants, and they wish they had removed the implants sooner. Now, at the 6-week mark, you start gently with those exercises, and then you work up. And the best therapist is basically the patient and I kind of direct them as to what and how to move to the next level.
What happens if 100% en bloc cannot be achieved?
This has to be achieved because there is no choice. This is to be achieved because this is the surgery that is required. The capsular tissue is the scar tissue, the inflammation scar that forms around any foreign object in the human body. So if someone has like a pacemaker or a lap port for chemotherapy or a hip implant or screws or plates, you will inevitably end up forming what is a scar tissue around. Now, in this case, when it comes to saline and silicone implants, 100% of the patients have this capsular tissue, that scar that forms around. And so it is very much visualized, and you will see the thousands of patients that I've operated on where their capsular tissue is so thin that it is transparent. So if I put the capsular tissue on top of a ruler, you can actually see the numbers. No matter how thin the capsule, it must be removed. Remember, this is the heart and gist of the surgery. I've interviewed, talked to a lot of other plastic surgeons. Talked to another plastic surgeon from the Netherlands, and I talked to a lot of other local plastic surgeons, and even at the conferences. This is what they have said repeatedly. Number one, they start dissecting. It's relatively easier dissection. Now, the implant capsule, when it was formed and the implants were placed long time ago, when the first, for example, a patient got implants 15 years ago. When they had implants, they were sitting relatively much higher up. So over time, because of the weight of the implant, they just gravitate downward and outward unless they have a capsular contracture. So now, 15 years later, when the implant is being removed, the implant capsule has moved down, and so it is easier, simpler, and more visualized as far as removal of the capsule on the lower part. And just like this nice plastic surgeon was saying, she goes and dissects further up, and it can get tedious and very challenging. And so she would then basically cauterize, burn the capsule, place a drain, irrigate, wash it out, and say that would be good enough for her. And in my practice, absolute no. Remember, this is exactly what I had said earlier. It has to be physically removed. So option number one, where the capsular tissue is cauterized, burned, and irrigated and drains placed, is a big no-no. In my practice, the capsular tissue has to be ultimately removed along with the implant capsule, such that there is no capsular burden remaining behind. Nothing is cauterized, and this is essentially the 4-hour commitment that it takes for me to doing the surgery correctly. And this is the one and ultimate only proof that you are visualizing the raw muscle on top of the chest and the rib. And again, as you will see now, the pictures coming together between no usage of the drains, between the high definition pictures and videos of the chest wall, between the plus minus 4 hours of surgery, between the surgeon confidence that he or she is sharing the pictures and videos with the patients, that ultimately proves to the patient that the surgery was done in the manner as described. And this is where the whole capsular tissue must be removed all the time, no exceptions. This is something we are not going to accept otherwise, because now the patient's not going to improve. And if the patient's not going to improve, we will have to now seek out another surgeon who will then remove the residual capsules. And again, going back to the point I mentioned earlier, do it right, do it correctly, do it comprehensively the first time, do it with definitive certainty, and do it with a surgeon who believes in breast implant. So that is key. If you have a surgeon who's augmenting and a surgeon who's explanting, I, as a patient, will never accept the fact that he or she will completely, sincerely remove the whole capsule, because why would he be, quote, putting in implants to begin with? Because ultimately all patients will succumb to removal of the implant capsule, because that is where the end result will always be inevitably be. If you look at the black box warning, the first thing that was highlighted by the FDA, by the manufacturers, breast implants are not lifetime devices. The longer people have them, the higher the chances are that they're going to have problems, some of which will require more surgery. They are not lifetime devices.
How do you determine if drains are needed versus not?
So, very good question. Now, ultimately, if you ask me, having presented at an international conference and shared my results and data with a lot of patients, when the surgery is done correctly, completely, definitively, which means if you take a marker and if you have to color a white piece of paper, you're literally millimeter by millimeter dissecting and removing the capsular tissue off of the rib. And this is the 4-hour commitment, and all of the bad tissue is removed completely, sincerely. The need and requirement for the drain is absolutely not there. To the point where if your surgeon's using drains, I step up and I say your surgery was done incorrectly. Because how many of my surgeons post-op have said, oh, the surgeon was great, but I needed drains? Not at all. Number two, I show the high definition pictures and videos that show complete removal of the capsule. Just like the other surgeon who mentioned that she cauterizes the capsule and she then leaves the drain behind after irrigating. Now the drains become mandatory. And what is unfortunate is not only for 2-3 days, but 2-3 weeks. And this is absolutely not, consistent with improper or inadequate removal of the capsule. Number three, because all the bad tissue is removed, there is nothing that's going to introduce or cause pro-inflammatory changes that will induce fluid formation. There is no spillage of the silicone because it was done correctly in the end block or 100% total capsulectomy. And now the drain requirement is not there. And as you will see, that in itself validates the point where the blood loss in well over 99.7% of the patients is less than 5 cc's. And when the surgery is done with pure respect to the muscle, to the breast tissue not being touched, between the all bad tissue removed, the drain requirement certainly is not there. And you will see my track record essentially points to the fact that even with the many ruptured implants, patients with implants in the 800, the largest one that I have removed, 1200 cc implant, the drain requirement was not there because the surgery was done comprehensively and definitively. The other thing I must mention is when you place drains, if the bulb syringe opens, that fluid can backtrack into the chest, and that can be a catastrophe because that's dirty fluid going into the chest cavity and the chest area, and that in itself will cause a lot of problems that will require a formal washout. The drains themselves, once they are going into the chest, if that nylon suture that's holding the drain against the chest wall, let's say, comes off, that whole tubing can go in and out and seed the bacteria that's on the tubing inside the chest, and that will be another catastrophe to manage. And the drains themselves, believe it or not, are a foreign body, and they themselves can be an irritant and can induce fluid formation. So going back to the point, I say to you, do not ask me why I don't use drains. Look at it the other way. Ask your surgeons why they use drains. And you will see when the other surgeons who are doing the surgery correctly and they're taking 5 hours or so, you will see they're not using drains because they have picked up on the idea that and the concept that if there is no badness remaining behind and the surgery is done slowly, definitively, that ultimately proves that the surgery was done correctly. And again, compounded by the 4, 5, 6 hours of surgery, 4 hours plus minus, high definition pictures and videos, the surgeon track record, and overall, if you look at the big picture, you have the ultimate peace of mind that the surgery was done in the manner as described.
If I need drains, how do I take care of them and how long would they stay in for?
So if you need drains, this is your surgeon who will give you a tutorial and tell you exactly what to do and how to manage them. The last time I used drains was well over 6 years ago. And any of those, so in those patients where I made the cut, this was, for example, an 81-year-old lady who was riding her car and spun on ice and ended up on a ditch, and she had what was a ruptured implant from the early 80s. She came to me a month after her car accident, worked up by her trauma surgeon, who stated that on the MRI there was free-floating silicone. So as soon as I made the cut, there was free-floating silicone. Another young lady in her 40s, she had excruciating pain from trauma to the chest, and she got kneed literally on the left breast area by her child, like her 6-year-old son, and you can see that trauma caused a lot of excruciating pain. So as soon as I made the incision, there was silicone pouring out. In that case, automatically the decision was made for me that I had to use the drains because this was extra capsular extravasation of this molten silicone, if you will, outside of the capsular tissue. So now, once the drains go in, I tell the patients, and the only person who can direct is the surgeon, not the nurse, not the medical assistant, not the front desk person, because the surgeon should be the one who placed it, and the surgeon should be the one who should be removing it. I see, unfortunately, many cases on social media where the patients go home to their respective state, and now the significant other husband is removing drains because this is again incomplete or bad surgery. So this is the surgeon's ultimate responsibility who placed the drains to be ultimately removing them, and this is very much patient and surgeon dependent.
So that ties in with our next question: who will remove my drains if I need them?
So the surgeon should and must remove them under the direction of the surgeon or another surgeon. And this is where I have not had any of those patients who had their drains were only removed by me. And remember, these are drains that will stay in the body 2, 3, 4 days when the surgery is done correctly, not 2, 3 weeks.
Right. What testing or labs are performed during my surgery?
So this is a very good question. Anytime I remove anything bad, i.e. questionable, suspicious, I will send it off, number one, to pathology. So they're going to do the CD30 analysis to rule out that rare lymphoma, which is the breast implant associated anaplastic large cell lymphoma, rule out the BIA, which is breast implant associated squamous cell cancer, breast cancer, abnormal cells. They will do what is non-polarizable light and to see if there's silica present or not, the inflammatory cells. And this is the pathologist's responsibility. Now remember, I basically direct this and tell the pathologist this is what you have to do, and you must document that the CD30 analysis was done. If there is any fluid around the implant, that fluid must be sent to cytology, and again, CD30 analysis must be done. Malignancy must be ruled out. It is malpractice to not send the fluid around the implant to cytology because you will potentially be overlooking cancer, lymphoma, amongst other problems. Then the other lab is the microbiology lab, which is where the cultures are done for aerobic, anaerobic, and fungal. And I get that representative sample in between the implant and the capsule so that if there is a biofilm present, we can treat that potential bacterial colonization effectively. And again, this is any mass, any abnormality, anything irregular, anything even questionable, abnormal, I remove it because my eyes cannot tell if it is malignant cancer or not. The only person who can tell is the pathologist because they have to stain it, look at it under the microscope under 100 times mag, and remember, they are trained to be looking for cancer and they will diagnose the problem. I find a lot of surgeons, unfortunately, they said the capsule was thin, so I just left it behind. Wrong. I looked at the capsule, it was benign, so that's why I didn't send it to pathology. Absolutely wrong. Or I looked at that mass and I threw it away. I did not want you to incur the cost of pathology. Absolutely wrong. Malpractice. Remember, any tissue of the chest of a female or a male, breast tissue and around, you have to always think accessory breast tissue or breast cancer. Remember, 1 out of 8 or 9 women will get breast cancer. So the surgeon has to be trained and has a team of docs who understand what is the explant process. When we moved to this location and I talked to the chief of pathology at the neighboring hospital, he himself told me, do you think it is not overkill for you to get a CD30 analysis on all your patients? Because the insurances will say there is some ethical responsibility you have about getting 100% of these tests done all the time. And I said to the chief of pathology, do you think if we don't do the CD30 analysis and we don't do the appropriate stains, you could potentially miss the BIA-ALCL? And he said, sure. And I said, why don't we treat every patient like the President of the United States? And that is what and how you have to look at it, because this is very well established in the literature today and by the plastic surgery societies that the BIA-ALCL is underreported, that associated pathology with implants is underreported because majority of the surgeons are not removing the capsule, and even in those surgeons who are removing part of the capsule, they're sending off to pathology, which is wrong. Where they're sending part of it off to pathology, they're not doing the appropriate stains, and even the pathologists are not interested in doing the stains. And now you have a lot of this potential BIA-ALCL being underdiagnosed and missed. And this is well established by the plastic surgery societies, not only in the United States, but Canada and Europe and South America, that BIA-ALCL is underreported, that its incidence is a lot higher than what we know. But because no one is testing, it is being missed, and it is being not checked thoroughly. And this is where, when it comes to explantation, do it right, do it once, do it correctly, do it thoroughly, so that when I look back at my cases in 2025, 24, 23, 22, 21, 20, 20, 19, 18, I have been very comprehensive and defined and definitive. And when it comes to explantation, that you have to take everything seriously. You do not want to miss. You do not want to be incomplete, and you want to do it right for the patient.
What type of anesthesia will I be given?
So this is a very good question. There is a 47-minute video on YouTube. We will have this up on our website. Anything and whatever you need to know about anesthesia. So just like a brief overview, if you want to get your gallbladder out and your appendix, for example, or colon resection or a major surgery, what happens is what is called general anesthesia, where you're paralyzed, and now a breathing tube is put into your, essentially down the throat into the lungs, the endotracheal tube, and now the ventilator essentially breathes for you. This is done every single day, from newborns to all the way to those patients who are 100 years old, done relatively safely. This is where you can have potentially, when you paralyze the patient, blood can pool in the legs, you can get clots, for example, or you have ventilator-associated trauma, where, let's say if the IV falls and now you're breathing against the machine because you start waking up, or you have a cough reflex or anything like that, and you're not maintained. It does happen, unfortunately, but that's part of what is the general anesthesia. Extremely safe, done every day in the United States very safely, and by very, very defined results. So you will have only minimal recurrences even after 100,000 surgeries, for example. Now, I say to my patients and to the many plastic surgeons and to the other docs, in my practice, I use what is twilight deep sedation, which means the patients are completely amnestic to the surgery. They're sleeping, snoring through the surgery. They have no recollection of the surgery. They're not paralyzed. There is no breathing tube breathing for the patient. And the patients are comfortable. They recover relatively well. There is propofol, fentanyl, Versed, and very defined anesthesia. And it is very proactive and relatively, I use the word safer. And I'll tell you, I've taken care of many patients. Their husbands are doctors, surgeons. And I took care of a patient earlier this year, the first week in January, where the first patient that I operated on, her husband was a anesthesiologist, and she herself was a CRNA, and they were totally confident and comfortable with the thought, because it is better, safer, nicer, and more effective. And I recommend to all the other surgeons, you should do it in this manner, because if you ask me, that gets the job done with least turbulence.
Will I need any medications prior to surgery?
So this is a very good question. Before surgery, I will prescribe to you an antibiotic. If you have no allergies, usually it's Keflex, that you're going to take post-op every 8 hours for 7 days. I will then also give you pain meds, two of which, one is likely going to be tramadol. Now, I ask my patients, what drug allergies do you have? What experience do you have with pain meds given their previous surgeries? And I tell my patients, you tell me what pain meds work well for you. And I direct it to them so that they're taken care of. Now, if a patient says, well, I don't remember, or it was the generic post-op medications, I will give you tramadol for intermediate pain and half of a Norco if you have any breakthrough pain. And most of the patients, well over 60-70% of them, do not need much of pain meds. Last week, I operated on in California, and all 5 of my patients, post-op day number 1 and 2, were all taking Tylenol. If that tells you basically what their post-op course is. 70% of my patients do very reasonably well without the need of much pain meds. The other 30% would be because they have had other multiple surgery, or they have pain dependence, or they just basically have high intolerance to pain. So overall, an antibiotic and two pain meds. And if you want to, you can certainly opt in for what is Exparel. This is the local nerve block that I give at a slight added cost, which gives you a numbing slash pain control at the local area where it's injected for up to 3 days. And relatively very effective, gets the job done very nicely.
Are there any medications or supplements that I need to avoid pre and post operatively?
So very good question. We see a lot of patients who are taking a lot of supplements. Now remember, these supplements are made in China, God knows where, South America, someone's garage. We do not know truly what are the ingredients. And just like any orthopedic surgeon or any surgery center will tell you, there is a big unknown. So unless the medication is prescribed by your MD, for example, vitamin D, safe. If you're taking, in my practice, hormonal replacement therapy because you're postmenopausal, my suggestion is continue doing that, because if you come off the hormonal replacement therapy, your body will go haywire. So I give everyone heparin sub-Q, which is to thin the blood enough for the surgery to prevent clots. Everyone gets squeezy boots, and I tell my patients to continue on with their hormonal replacement therapy. Any medication that was prescribed by your doctor because your numbers were low. Just like when you go look at your fuel gauge in your car and the gas is on empty, and then you have to kind of add more. If your iron levels are less and they added iron to your medication list, so you continue to take those. But if you have this supplement, God knows where it's made in or what are the ingredients, prescribed by a nutritionist or a holistic doctor or a functional medicine doctor, this is a big no, because there's a lot of unknown. There are patients who are taking supplements and their potassium was 5.5. It turns out it was one of those supplements. These medications have essentially sometimes just calcium in them because there is no regulation of these supplements. So you should and must stop these supplements. And there are thousands and infinity number of them because they come from all over, like turmeric. You don't need that for the surgery. Stop whatever is not prescribed, that's over the counter, that's a supplement, because we do not want to take chances for your surgery.
Do you provide any anti-nausea medication if needed?
So if you need, I can certainly write for the scopolamine patch that goes behind the ear, or I can write for the Zofran, which is a good, very effective anti-nausea medication. Now remember, if you look at the side effects of the anti-nausea medication, they in itself are a handful. So there's always risk versus benefit. So I tell my patients, on the day of the surgery, you're out of bed to chair, you're not pushing yourself to eat or drink. The following day, you are up and about gently, and you will be as sharp can be because the anesthetics have worn off. Gentle walking will make sure that your gut is moving, that you are moving your bowels, you're not constipated, and that will in itself minimize the nausea. Now, sometimes there is a nausea effect from the pain medications itself. They cause GI distress or some GI dysmotility that in itself can get you nauseous. So the goal here is you want to have this fine balance. Some patients, for example, on the day of the surgery have been nauseous, they vomited because they ate too much too fast. Remember, you got an IV. If anything, you were fasting probably for 8-12 hours. That's no big deal. You want to go slow the first 24 hours and your body will catch up. You have enough of a glycogen store so that between the glycogen in the liver and the muscle, you will be able to basically keep up with your optimal glucose supply. Now, there are patients obviously who are diabetics, for example. They need to monitor and they need to continue on as, they know their body the best. But overall, if you overcome the hump of the first 6-12 hours, most of the patients do extremely well in general with the surgery.
Am I able to take my implants home with me?
So this is a very good question. I return the implants to the patients all the time because so that they know that the model serial number of the implant matches the card that they had. It basically is a mental closure as well, that they know what was inside their body. You will be surprised 10-15% of the times, the patients are totally surprised by what was removed. One patient signed up to get saline and she ended up getting silicone removed. Another patient thought she had smooth implants and it turned out she had textured. Another patient had allergen on one side, mentor on the other. Another patient, I remember vividly, she had on her card a serial number that did not match the serial number on the implant. Remember, this is very important for you to even know that your surgeon did not puncture the saline implant on the way out. So there is a lot of reasons why you want to get your implants back. And remember, if you do not want to keep them, you can certainly return them to me, to our practice, and we will discard that off as biologic waste. Some patients like to keep them. There are some patients who have reached the manufacturers directly and they have gotten like a check from Mentor, for example, or Allergan because of the contract that they had, because they had like a warranty on them. So again, depending on what the patient's choice is.
If you find any fluid, hematoma, or seroma, how will you proceed?
So anytime you have any fluid around, so I have a patient coming in the next couple of weeks. She already had her explant done and she has what is a seroma, which is a fluid collection, because this was an incomplete job by the previous surgeon. So I'm obligated, like I said earlier, to take that fluid and sending it off to cytology so that they can do their appropriate tests on that fluid, making sure it's not that rare lymphoma. The CD30 analysis will be done. I will send any of that residual capsular tissue to pathology. Now, hematoma is basically a collection of blood that can be old from the fall or trauma. So that 81-year-old patient who had the car accident, she had silicone and hematoma in her chest on the right side. So that is the old blood. Now, if this is fresh blood, if you will, this is immediate post-operative after, you will see it's under a lot of pressure. And so the patients will feel that instant tightness. Now, if I may use this as an analogy, if someone, and this might be the only way to kind of help you understand this, unfortunately we see as physicians someone who slit their wrist for suicide, you will see that's under arterial pressure, a lot of pressure. If someone gets an arterial hematoma, it will fill the chest up instantly, very fast, within a few minutes, and it will be unbearable. The patient will not be able to breathe. So that is a immediate post-op hematoma. This is something where you want to call your surgeon or call 911 because you need urgent evacuation. A drain is not going to prevent a hematoma. So that is a complication in two ways. Number one, that the surgeon did not do the surgery correctly, and it occurs within 4, 6, 8 hours right after surgery. If the patient a week or two starts to stretch or move their arms about and they pull a muscle, that can also lead to a hematoma, so non-compliance. So going back to this question, I have had only 2 patients within the past 10 years where they had a hematoma within the first 24 hours. The last one was 2 years ago, where the patient I operated on, a 42-year-old nurse at the hospital who had COPD, and post-op she had one nurse was managing 2 patients. And so my patient literally got up and turned around because she wanted to sleep on her side and onto her stomach because she was a side and a stomach sleeper. And that in itself, within recovery, I noticed that she had what was a hematoma, and it was a direct result of not being compliant with her arms. And unfortunately, this was something that I had to take her back to the operating room, like literally right away. The other one occurred where at 10 o'clock, this was almost 2018, 8 years ago, where the patient had at 10 o'clock at night called me and said, my left side is much larger than the right. And I said, don't eat or drink because we have to go to the operating room first thing in the morning. And this is something that I evacuated, and this is something where it absolutely does occur. Now, the other times where it occurred was where the patient started moving their arms. They were non-compliant, and they stretched the muscle. One lady in the morning stretched her arms because she was not in any pain, and she ended up having this hematoma. Remember, it can occur after any surgery. especially this one because of the way that dissection is done involving and around and below the muscle. And so the bottom line here is this is what is a hematoma. The seroma is a fluid collection, if you will. This is like a waterbed, if you will, like a water bottle. The fluid accumulates. This is where the patients, for example, are non-compliant with their bra and binder, or they're moving their arms about a whole lot more. And this is something that easily is managed by going back to the restrictive T-rex arm phase with the bra and binder. This in itself, the body absorbs. And so patients, I did a Facebook Live with one of my patients like almost several years ago, where a patient had a very large implant. Patient was morbidly obese in the BMI of 35, 34. Patient had implants above. These are patients who are more prone to getting a seroma versus smaller implants below the muscle, and who basically have a lower BMI.
What are the risks of explant surgery?
So we talked about the hematoma seroma. I will say to date, I have had only 2 cases of questionable infection. And I'm very blessed to state this. These 2 patients were managed by a general surgeon who, for billing purposes, wrote down infection because it pays better. This is where the patient had a small open wound. This is unfortunately occurred in these 2 patients. But overall, from an infection perspective, we've had very, very good results. I've had very good results where the patients, when they are on the post-op course for antibiotics, remember their intact immune system is going to fight something that is basically very, I use the word extremely, extremely unlikely, where all the badness is removed and the surgical tape and the bra binder is usually left in place for 6-7 days post-op before the shower. And so I have had an excellent course for these patients. I have had only one pneumothorax, which is the air within the lung. This was very early on, almost 7 years ago. And this is a patient who, remember, this is, if you ask 1,000 plastic surgeons in regards to explantation, they all will state that this is very risky and invasive, and this is the one reason, which is the pneumothorax, which is air within the lung. And this is truly, yes, it is invasive, but it needs to be done. If you can say neurosurgery is very involved and dangerous, or just like open heart surgery, or even gallbladder surgery, or even putting in a G-tube, or a colon resection, all surgeries are involved. Anything can happen anytime. But this is where the surgeon's expertise, experience comes into play, and the confidence into doing the surgery. And remember, going back to my initial point, this is a surgery that I do routinely below the muscle. And this is where I have done this repeatedly from one patient to the next. And the outcome for that patient with the pneumothorax, where she ended up getting a small drain, the air was let out, she had to be admitted at the hospital. The lung in itself essentially re-expanded, and then she was discharged to home. This, unfortunately, is what is the dreaded complication when it comes to explant surgery. Overall, another way to answer this question is almost 80% of my patients travel to see me. That means they travel far away, be it in a car or they travel by plane, train, bus, RV. And this is a surgery where I can offer them the service with confidence, where when they do come to me, they will come and see me on a Monday in clinic prior to the surgery. This is part of the informed consent. You do not want to see your surgeon the day of the surgery. The surgery would then occur on a Tuesday. They would then recover Tuesday, Wednesday, Thursday. Friday, they would see me, and they would have had 2 days easily to declare themselves. And this is where, when the patients head home, I'm able to very comfortably, very definitively, and very comprehensively, I myself, talk to the patients so that they have the best post-op care. I give my cell phone number to all my patients because I only know what happened inside the operating room, and I'm only able to better direct them. So if they had a ruptured right implant, that would be the limiting part for their recovery, and I direct that post-op, and I'm very much hands-on when it comes to the post-op instructions so the patients get the best experience. Going back to the point, if the patient, I remember, for example, from Iowa, she had a radiated chest, and she had a high BMI, I automatically refused her surgery because she's going to have problems because of the radiation and the rupture, and she's set up for potential problems. And this is where she's going to be better managed by her local surgeon.
What type of garment do I need, and how long will I need to wear it?
So when it comes to, this is a very important question. In the world of plastic surgery, you do a tummy tuck, you have to wear the compressive garments. You do a thigh lift, you have to have compression there. You do arm lift, you do gynecomastia, male breast surgery, you have to have compressions. Likewise, when the explant surgery is done, you have to have compression with the bra. That in itself will hold the breast tissue nicely, and then the binder that will reinforce and hold the breast tissue such that when you're on a bumpy ride, there's no vibration or shear forces on the chest breast area. And this is where it allows for better post-op pain control, certainly. And number two, it allows for everything to be held nicely, especially that big void where that 2, 3, 4, 5, 600 cc implant was sitting. And this allows for better healing, less swelling, and optimal result. Remember, this is plastic surgery 101. Anytime any plastic surgery is done, like I said, be it a tummy tuck or any of these, compressive garment is essentially required. And to not wear a compressive garment is malpractice. So this is where you will see there are industries, there are companies that are specifically geared towards helping post-op patients who wear these compressive garments, such that the patients get the compression that is required post-op.
Can I exercise or lift anything heavy after surgery?
So remember, the only activity you're allowed is lifting no more than 2 pounds, and you have to be what is T-Rex arms. You cannot be moving your arms out because we do not want to engage the muscle underneath which the implant was sitting. And this is extremely important. Just like after a tummy tuck, you're not going to do sit-ups, push-ups. You're not going to bend, push, pull. You're going to walk, number one, slow motion like an 80-year-old person, and definitely not recommended but required to walk post-op day number one. On the day of the surgery, you're up in a chair. But then you are going to be limited in your arm movements just like you would after a tummy tuck. At the week 6 mark, plus minus, I have the patients initiate gentle exercise therapy such that they themselves will be the best therapists. And they start off with the bicep curls 1 minute, 2 times per day. The second week, 2 minutes, 2 times per day. Third week, 3 minutes, 3 times per day. So you're upping not only the number of minutes, but the number of times. And then the fourth week, 5 minutes. And not only are you building the pec major muscle, but the pec minor, the latissimus, the deltoids, the serratus, all the muscles of the neck, back, shoulder, including the infraspinatus, the trapezium, and you will be better than ever before. And I will say this, there is no other better therapist than me and the patient, so that I direct to them what to do. You do not, as a patient, want to go to a therapist who will then have you do all these upper range of motion exercises, and that will compromise your result. Remember, this is a surgery that is very invasive. You want to have a very nice, systematic, thoughtful approach to the next level without compromising the results.
If I have any questions or concerns after surgery, who do I call?
So this is a very good question. If you go through and listen to all the questions we talked about, this kind of covers what would be the gist of what is explant surgery. Now, this is extremely important, and I'll close with this. You, as a patient, you have to go to the surgeon's website, YouTube page, YouTube shorts, YouTube videos, YouTube lives, Facebook, Instagram, and you have to follow the surgeon's mindset, their mentality, their thought process. After a day or two, you will get a very good vibe about what the surgeon is about. After a week or two, you will definitely feel very comfortable. After 2 months, you will be very informed. After a year of just seeing the surgeon back and forth, you could give a lecture on the surgeon's practice. And this is where you are going to be your own advocate. You're going to educate yourself. Let me give you another example. Here is a patient, 65 years of age, had implants 15 years into her chest. She goes to a plastic surgeon who inevitably says it's time for you to remove these old set and we'll put a brand new set. This is unfortunately the answer, not 99% of the time, 100% of the time. And this is where I tell you as a patient, if you have implants that are 15 years old, just walk into the surgeon's office and don't say a word and say, what should I do? If your surgeon says, replace the implant, my recommendation to you is run, because you can see that he or she is not invested into removal of the capsule, and you cannot twist the surgeon's arm and say, please do this, because if it's not going to come from the heart, it's never going to be done. One free soldier is better than 10 hired ones. Unless it comes from the heart, the surgery will be done incorrectly. Now, if you go in and you have to request, persuade, you have to demand slash beg the surgeon to doing the surgery, this is not your surgeon. And as you will see, it has to come from the heart. Now, within the same surgeon's mindset, if the surgeon says, I have had patients that came to me and said, I will pay you whatever you want and I want you to replace them. And I said, absolutely not, because that's not what I believe in. I have had a patient that stated to me that she would want only one side done and not the other. Very interestingly, because that was the newer implant. And I said, absolutely not. I only removed them in the manner as described. Another patient came to me and demanded that I put drains in, otherwise she was not going to come to me. And I said, unfortunately, I'm not your surgeon. I'm not going to put in drains because you asked me. I'm only going to put drains in because they're required. I myself am the surgeon, and I have that confidence and the experience and the expertise to deciding that you do need a drain or not. And I have had patients that came to me that stated, if the capsule is thin enough, leave it behind because I don't know. And I said, that's not my practice. And this is where that informed consent comes in. You as a patient need to understand the mindset of the surgeon. What is their etiquette? What is their thoughtfulness? Now, within a group of surgeons who claim to be only explanting, you have to understand why and how they do it. Do they do it plus minus 4 hours? Do they return the implants to the patient? Are their incision lengths the same size, the diameter of the implant? If you have an implant that's 600 cc's and the surgeon's going to do like a 2-inch incision, I guarantee you 100% that end block or 100% total capsulectomy will not be done. So that length of the incision essentially dictates or is dictated by the diameter of the implant. So the timing of the surgery plus minus 4 hours, the high definition pictures and videos of the chest wall showing complete removal of the capsule, that is the ultimate and the only proof that the surgery was done. The capsules being sent to pathology, that's also key. If the surgeon does an explant and a supposed capsule removal complete, they should send the capsule off. And remember, anytime the capsule is sent to pathology, the first thing that the pathologist does is measures with a ruler. So if you had a 600 cc implant and the capsule is 3 by 4 centimeters, you know with absolute certainty the entirety of the capsule was removed. So your surgeon should be sending the capsule off to pathology. And number 7, your surgeon must have a track record on social media, Instagram, Facebook, TikTok, YouTube Shorts, Lives, and validated by the many surgeons who have gone to that surgeon that authenticate, certify, validate that your surgeon is not making up stuff and that he or she is a firm believer. I find, unfortunately, there is a group that wants to buy my practice, and they felt that I was doing an inefficient job marketing to the right people. And just out of curiosity, I asked that surgeon, what is it that they would do, just out of curiosity. Obviously, I was not going to follow through with that. They said, well, they would continue to keep me as only explant, and that they would hire another person who would augment to capitalize on those other patients who are wanting to augment, and they would keep them separate from me at the same facility, and which is a big shame and unprofessional, unethical behavior, because ultimately the surgeon wants to capitalize on making more money. Remember, this is a surgery that is involved and it has to be done from the heart, because if it's not done, you're going to get the compromised results, unfortunately, which is what happens from one patient who has gone to another surgeon who's only explanting, because they're done with the surgery in 2 hours and they're doing 4 of these in a day. I was in California last week, 8 days ago, and there was a seasoned experienced anesthesiologist who had been to a lot of these plastic surgeons in the greater Los Angeles area. Now, when he saw my 3 cases that I did on a Saturday and 2 on a Sunday, he said, I've been to a lot of other surgeons who explant exclusively, and no one comes even close to how you're operating, and you're pouring your heart and soul in this whole process. And I said, you bet. Because I talked to these other surgeons, or I've been on Zoom meetings with them, and again, goes back to they cannot reproduce those high definition pictures and videos, and it's all about the tedious dissection. And he said, almost all the other surgeons who are exclusively claiming themselves to be explant specialists, they're done in an hour and a half, 2 hours, 2.5 hours with the left, and they're doing all this liposuction and fat grafting, which is an absolutely big no. And this is essentially where you yourself, as a patient, you have to understand how and why your surgeon is doing it. And I find that if you do your homework, you will get that firm determination that your surgeon is committed into your well-being, that he or she is going to remove the entire implant capsule and all of that inflamed tissue in the manner that we have described in this setting. Do your homework, go to the web page, do your research, talk to the previous patients. After some time, initially you might be overwhelmed, but after the 2nd month, 3rd month, you will see the same set of questions essentially repeating themselves, and you will hear the same theme repeated over and over and over again. And this is where not only will you be content with your decision making, but as you will see, most of my patients, if not all, are excited about their surgery because they know their good health awaits them. And this is where you yourself, you have to do the homework, you have to do your due diligence so that you know what you're signing up for. This is, and I will end with this, you have to be your own advocate. You have to speak for yourself.